Thank you. Good evening, dear doctors. I'm Dr. Harshvi Singh Mali. I'm the head of medical affairs for oncology at Merck India, and it's our privilege to have you all attend for today's scientific webinar on informing choices, applying clinical trials and real-world data to bladder cancer management. For the meeting today, we have quite an interactive session which has been planned out. After the brief introduction from my end, we'll be inviting Dr. Ashok Vedsar, who is the chairperson, for his chairperson's address. And we have Professor Alison Bertel, who will be joining us for the keynote lecture on informing choices, applying clinical trials and real world data to bladder cancer, followed by a moderator session on illuminating the optimum management of advanced bladder cancer, led by Dr. Vineet Talwar sir. And finally, we'll have the closing remarks coming in from Ved sir. Without further ado, it's our privilege to have Dr. Ashok Ved sir as the chairperson for today's session. While sir doesn't require any introduction, but being a formal platform, it's our privilege. Dr. Ved sir is the chairman, medical oncology,
Harsh,
hematology, and
Harsh,
stem
we
cell
can
transplant.
move on. Sorry to interrupt. We can move on. It's a very familiar audience,
And thank
We
you so
can
much, Ved
definitely.
sir. Over to you, Ved sir,
Yeah, thank you
for
so
the
much.
chairperson session.
Thank you so much, Harsh. And many thanks to you, Harsh, and your team for putting up this very interesting program this evening. And we have the honor and privilege of hosting Professor Alison Bertel. We have read uh, the the trial, path-breaking trial, the Lancet 2020 publication. Am I right? Yeah. And I think I'll just set the context by presenting to you very briefly about urothelial cancer and one of our cases we've been treating over the last about a year and a half. The demographics, what you see on the left-hand side, the bar diagrams tell us that if the disease is indeed local or localized, the outcome is going to be good. But even for those, what we see at the bottom part of the slide is that those who undergo a curative surgery, a good 50% are going to come back even after a cystectomy. And therefore, the neoadjuvant approaches which have been evolved over a period of time have gained traction. Thankfully, because this is a mucosal disease, the number of patients who present with diagnosis is a small number. But indeed, those who develop a metastatic disease are not long-term survivors. And that's what we need to improve. It's an area of unmet medical need. And despite our advances in the recent past, we continue to grapple with resistant disease over a period of time. And majority, as we see, would come back with metastases which are in the distant organs. And therefore, that's a challenge medical oncologists continue to see in the clinic. Next. So the history of the drug development or the drug introduction for locally advanced and metastatic urothelial cancers. So 30 years, there was actually a hiatus, a long hiatus when nothing happened. And gemcitabine came in the year 2008. And in the last 7 to 8 years, it's been a crowded segment with the immune checkpoint inhibitors leading the pack. And what one can see that there are different approaches of combining single agents and the conjugates, the segment getting crowded. And we have chemo plus IO as well as one of the options. So through the discussions, we would see what is the best and what is evidence based for our patients in the clinic. Next. So this is a patient, 73-year-old gentleman, no history of tobacco, and presented with some very vague symptoms, investigated for those, and was found to have a 5 by 3 centimeter mass along the left posterior lateral wall involving the left VU junction, and in addition, a couple of other polypoid lesions as well. He underwent a pancystoendoscopy with the TURBT in August 2023. And this was a muscle propria involved by the tumor, and patient opted for a bladder preservation. Next. And in October 2023, soon enough, he developed a nodal disease and a bony disease. And patient had a progressive rise in the creatinine, and therefore he was not a cisplatin eligible patient. He was planned for chemo and for 4 cycles with carboplatin based on his GFR, and there was a good response, almost like a CMR in the pelvic lymphadenopathy and the bony disease as well. And basis the good response, next, he was chosen for a maintenance. Next slide, please. For Evolumab, which was initiated after 4 weeks of the last chemo. So from Feb 2024 till date, he's ongoing and he has had his maintenance therapies, doing very well, and continues to be in a CMR and tolerating well and responding well, both the endpoints being met. Next slide, please. And I'm sure all of us see these cases in the clinic, and these are the stories every medical oncologist is going to replicate. But that is the power of the immunotherapies which have been realized in metastatic urothelial cancer. And we intend to, through the presentations, understand the treatment strategies for locally advanced metastatic urothelial carcinoma, to discuss and apply these evidences in clinical practice, as I already alluded to, and to optimize the treatment sequence to maximize patient survival, because nothing would work forever in a metastatic disease. I have the next slide, please. I have the privilege of and the honor of introducing our guest speaker, Professor Alison Bertle. The biography runs into several pages, which is quite expected because she's at the forefront of research in urothelial cancers. And as you see, she holds multiple academic positions and the lead positions in various universities in the UK. And as I said, the POUT trial, which was Lancet 2020, the path-breaking trial and a practice-changing trial in the adjuvant setting. And she was the principal investigator of that trial. And she has international and national positions on various guideline committees of the NIH, of the EAU, and many other bodies. So, Professor Bertle, pardon me in the interest of time to sort of compress this, but the other side is being a very accomplished professional. She is also a very passionate advocate of clinical equipoise in studies and the mantra of her trial for every patient, which is so very important. And also she combines the professional enthusiasm with the enthusiasm for singing and performing musical theater and love of rugby, cricket, and football. Professor Bertle, it's an honor to have you on the program this evening. And as I said earlier, it'll be a bigger honor to have you host you in one of the meetings here in India. Over to you, Professor. Thank you so much.
Thank you so much for that lovely introduction. And I hope you picked out that I am an enthusiastic cricket supporter. I've seen England play India many times over the years at Old Trafford and at a number of other venues across the UK. So if you can manage to coincide my trip to a time when India are going to be playing cricket, then I'd be even more enthusiastic about coming. And just to say that, of course, the updated version of the POUT trial, which is an upper tract disease, which is a different disease to bladder cancer, was actually also my first authored JCO paper, for which I have to thank all of the patients that went into our study, particularly our patient reps. So I'm so pleased that you've asked me to share today's symposium, which I think is really important. And as we've just seen, from Dr. Vaid, the key thing here is that patients have such an unmet need. Patients are not getting to us. They're not seeing oncologists. And we're not perhaps evaluating patients as holistically as we might do. And I think we'll probably cover that in the introduction. and in our discussions. So these are my disclosures. Perhaps the one that I'm most proud of is that I'm a medical advisor and trustee to the advocacy group Fight Bladder Cancer, which has a global representation, although it was set up by a British patient, Andrew Winterbottom. So there's a big difference, isn't there, between what oncologists think a patient wants and what a patient actually wants. And I describe this as this balance between treatment efficacy and quality of life. So for a patient, we need to discuss the goals, the gains, and the pains of an individual treatment. And so this was a survey looking at what oncologists thought was most important, which was clearly overall survival. Now, I don't think any of those oncologists were actually patients at the time. It would be interesting to know that, wouldn't it? But I doubt it. What did patients want? Patients wanted quality of life as the most important factor that they had. And we need to have this shared decision making, which has become a bit of a trendy phrase. But what it actually means is all of these things together. So we put together in a discussion with the patient, which does take time, about the different options. How do they work? What is the survival? What is the level of evidence we have for those treatments? What's the scheduling? What's the duration? What's the experience of other patients? What's the quality of life and the side effect profile and the tolerability? What might the options be in the future, depending on what patients have already had as the first line treatment? What about access and cost? Because that's, I know, is as important consideration for your choice of treatment and your patients as it is for mine. And what is the patient preference in all of this, which is perhaps the most important aspect? So let's go back to ASCO 5 years ago, to the Javelin Bladder study. Despite all the fuss around EV302, which I'll go on to a moment, Javelin Bladder 100 was the first proper practice-changing study in first-line bladder cancer that we'd seen since the original Vandermas study back 23 years earlier, which was the proof of chemotherapy with GemCis versus standard MVAC at the time. So Javelin Bladder was the first practice-changing study. Then we had ESMO 2023, when we had even more fireworks and people cried halfway through. Tom Poles, who's one of my great friends, presenting the EV302 data. And we also had the Checkmate 901 sub-study, which I have in brackets for reasons that you'll see during my my discussions today, which are slightly biased. So this is the current treatment landscape in advanced or metastatic urothelial carcinoma. And I make no apologies for the fact that I have kept in this thing of platinum eligible at the beginning. And this is because in Europe, our licensing for choosing or being able to choose, if we can, the combination of EV Pembro is in patients who are platinum eligible. So I make no apologies for keeping this part in. But you can see, if we look at the first line landscape, obviously we have choices, and those choices are going to be affected, as I've just said, by things like reimbursement, by cost, by patient preference. But isn't it nice that we have got choices now, rather than back in the pre-2020 era? Obviously, what we do in the first line setting will then dictate what happens later on down the line, for which we have far less data other than for the use of erdafitinib in patients with biomarkers, particularly less data if we choose EV Pembro. So I'm going to look particularly at this first line setting here. So let's start off with platinum-based chemotherapy, patients who have 4 to 6 cycles and then go on to receive maintenance avelumab, the checkpoint inhibitor, given on a 2-weekly schedule. Those patients have to have had a scan after their chemotherapy to show that they have either stable disease, partial response, or complete response. So chemotherapy is still a pretty good option for our patients. And when we look at response to chemotherapy alone, about 80% of patients with advanced urothelial cancer will achieve some response with chemotherapy. And this isn't a fluke. We've seen it across every single study with chemotherapy when you've looked at platinum-containing treatment, irrespective of the regime. And you can see here how it's divided into complete response, partial response, or stable disease. But the majority of patients do achieve a response. So this tells us that there's a high probability of patients being eligible for maintenance treatment. But sadly, real-world studies do show significantly lower rates of first-line systemic therapy use, and that reflects on what I was saying before about patients seeing an oncologist. We know from real-world data that between a third and 3/4 of patients with this disease never see an oncologist, and about only 50% of patients who are eligible do get chemotherapy, and that's on a good day, to be honest. But we know that this means that patients will be able to go on to chemotherapy, onto maintenance treatment, and as we've seen earlier, the duration of response to chemotherapy is not lifelong. Patients do progress, and so there is that need for maintenance treatment to try and address the challenge of chemotherapy resistance. So this was the Javelin Bladder 100 study, which we're all very familiar with, which was a large study, patients having a minimum of 4 cycles of combination chemotherapy, then no more than 10 weeks before they went on to maintenance treatment or best supported care alone. And they obviously had to have stable disease, partial response, or complete response, and had some really important endpoints. Most importantly, to my mind, alongside response rate, was safety and tolerability. So what did we see with this? Well, this is why the fireworks went off in 2020. There was a survival advantage, and it was huge in terms of overall survival. Not as much in progression-free survival, but is that as important to patients? No, as long as their side effects and their quality of life are maximized. And we know with checkpoint inhibitors that as long as patients continue to derive clinical benefit in the metastatic setting, we continue with treatment. So I'm not particularly bothered by that PFS response being shorter. The important thing here is that huge difference in overall survival of 9 months. And when we have longer follow-up of these patients, as was published last year at ESMO, the conditional survival of these patients continuing on maintenance therapy is very good. So this is looking at patients who are on long-term treatment, median overall survival over 29.5 months. That's very good, really, isn't it? So, and this is also what we see in real world practice. We've seen a number of publications only a few weeks ago at ASCO GU looking at data from Czechoslovakia, from Japan, from France. We've got the UK data, and these really show that these long-term outcomes are achievable in our patients. They're not just super fit patients who are treated in clinical studies. Does this sound familiar, this 29.7 months? Well, I'll ask you to bear that in mind when we look at the EV302 original data. So what about safety outcomes? Well, we've all been using checkpoint inhibitors for years now in urothelial cancer. Initially in the second-line setting, we may have done combination with chemotherapy in the first-line setting, which, as you know, is negative. And we may have been involved in studies looking at it in other settings in urothelial cancer. And there was no big surprise in Javelin Bladder 100. The safety toxicity was very similar to what we've seen in the study, and it was similar in patients who had 2 years or more of follow-up within the study. This is the data I was really excited about from ESMO last year, which I could go back and tell patients the next day, which is that if they had been on treatment for a year, their chance of being on treatment for another year was 93%, and their chance of being on treatment for another 2 years was just under 80%. And if they'd been on for 2 years at that time, their chance of being on it for another year and a half was 90%. And that's incredible, isn't it? We couldn't have begun to imagine that survival data for patients beforehand. And there were no new safety concerns, which obviously is very important for patients. So when we look at safety concerns, then we do have validated quality of life tools with all of the caveats around whether those are effective or not. But we also have our own eyes when we see the patients. But if we look at the quality of life tools used in Javelin Bladder 100, we can see that patients said, 3/4 of them said that despite the scheduling, which is obviously a 2-weekly schedule, that there was no change in how much they were bothered by treatment side effects throughout those 2 years of treatment. So that's very reassuring and something that I see reflected in my own patients. Now, this is a twist analysis, which I think is really useful because what it looks at is the combination of survival and delaying in progression. And again, you can see what this means here. Twist is the time without toxicity or symptoms of disease progression. The gray is time with toxicity, and the REL is the time after progression or relapse. And you can see that the twist bit, which is the time without toxicity or symptoms of disease, significantly better in those patients on maintenance of avelumab. So I'm excited now to also look at how much chemotherapy do I need to give in this setting. At the moment, I try and get my patients through to a minimum of 4 cycles because that's the trial data. And sometimes it can be difficult, can't it, to actually get to that point. So this is Tom Pole's study, the DISCUS trial, which is looking at patients having 3 cycles in the experimental arm versus 6 cycles before going on to maintenance treatment. And that will obviously collect quality of life data as well as prognostic data. And I'm really excited about this study. So that's looking at our chemotherapy switch maintenance. I'm going to spend a little time now looking at the cisplatin only eligible patients and talking about the sub-study of CheckMate, which was GemCis and nivolumab. Nivolumab being given concurrently with chemotherapy and in the maintenance setting. And this is the study. It was a sub-study of this particular CheckMate 901. And some of those patients also received avelumab maintenance if they've responded to chemotherapy. I'd just like to flag that there are 2 components to this study. The first was a combination and then a monotherapy phase with nivolumab. What I find interesting is that all of the studies with combination chemotherapy and immunotherapy in the first-line metastatic setting, whether that's been with atezolizumab or pembrolizumab, have been negative. So what do I think about this study? Personally, I think it's the adjuvant bit that's the important bit. It's this bit here. It's when they go on to the adjuvant nivolumab, because that's when the curves start to separate at 6 months. So is that any different from what I'm currently doing with chemotherapy switch maintenance in the cisplatin or the carboplatin eligible arms? And is that enough of a difference for me to change from what I'm currently doing? Well, I guess you can probably tell by the tone of my voice that the answer is no. Not enough to change from what I am comfortable with doing at the moment. So because of that, it doesn't really matter to me that the updated quality of life data was produced at ASCO GU a couple of weeks ago, because I'm not interested in the data myself. You may have different thoughts. So what about EV Pembro? Let's go back to that glorious moment at ESMO 2023 when Tom stood up and produced the survival curves of this juggernaut of a trial. Remembering as well that this in the study was for patient all comers. They could be platinum eligible or ineligible, but in Europe, the licensing for this combination is around platinum eligible patients, which is why I still have it in. So this was the study, which I know you'll be very familiar with, patients randomized to chemotherapy, which could be either GemCis or GemCarbo or EV pembrolizumab, EV being the antibody drug conjugate and pembrolizumab being the checkpoint inhibitor. Just a word of caution here is that the one subset of patients where we don't have the current data is there was a protocol amendment towards the end of the study, which allowed patients in the standard of care arm, chemotherapy, to go on to chemotherapy switch maintenance. And what we have never seen thus far are the results for those patients, which may be different. So And also that's about a third of the patients in the study. So these were the OS and PFS outcomes. And of course, these were updated again at ASCO GU a couple of weeks ago. And you can see a whopping great difference for these patients at 12 months, 18 months, and now at 24 months, although that data is not on my slide. But you can see that the difference was 31.5 months median overall survival, 12.5 months progression-free survival. But as I've already said, we often treat with the checkpoint inhibitor beyond progression when a patient is deriving clinical benefit. So I'm just trying to make you think as I have challenged myself to do when interpreting trial data for all of my clinical career. But obviously significantly better than chemotherapy, doubling the survival, and this was well deserving of all the praise. There has been an independent, independent patient data meta-analysis of all of the studies so far, which have had immune checkpoint inhibitors in them. And I found this quite interesting. So this was published at the end of last year. And what it showed was it took together the Checkmate 901, EV302, IMvigor 130, Keynote 361, which are the ones with atezolizumab and pembrolizumab respectively, looking at combination or monotherapy or chemotherapy, and the Javelin Bladder 100. And what you can see is that within this, none of the studies in this independent patient data meta-analysis, when they went, the individual patient data, so they're looking at each patient within each of those studies, there was none of the studies that showed a statistically significant advantage against avelumab, and the analysis started after the first chemotherapy phase. So that's interesting. So these are the response rates that just break it down into more detail with EV Pembro, and you can see that the duration of response we've talked about and the overall response rates here. So what I also find interesting is that compared with chemotherapy, there wasn't a huge difference in patients with progressive disease in the combination group versus chemotherapy arm. The devil is always in the detail, really, isn't it? So going back to quality of life, using the PROMs within the study, time to pain progression, change in pain, change in worst pain, and quality of life were either maintained or better with the combination arm. But if we look at the toxicity data, now you may have more experience with EV Pembro than I do. I've used EV monotherapy and I've used EV with Pembro, but all of those with patients in the studies. It's different to chemotherapy, isn't it? So although the rates of toxicity may be similar, as you can see on the right-hand side, there were more treatment-related emergent events leading to stopping, more treatment-related emergent events leading to interruption, and dose reduction in the EV Pembro arm than in the chemotherapy arm. And that was because of some different toxicity profiles, predominantly things like sensory neuropathy, this thing that I haven't put on this slide, which is the rate of hyperglycemia and lactacidosis, and also rash, together with fatigue. Now, some of these are manageable with dose reductions. The peripheral sensory neuropathy is very difficult. And of course, once you get a grade 2 peripheral neuropathy, that is affecting daily activities of life with patient. Grade 1 is one that is asymptomatic, but we might have picked it up because we've tested patient reflexes, for example. So if we look at the dose interruptions and discontinuations, just to compare the number of patients, you can see that there were more in the group of patients with EV Pembro than with chemotherapy. So does this actually have an impact on exposure and efficacy? Well, when it comes to this combination, we don't know. What we're doing is inferring data from EV monotherapy studies in the second-line setting, where it does seem to be that there may be a difference in terms of efficacy and exposure, but at the moment, the data is still out for the combination of treatment. When we look at the special interest treatment-related emergent effects, I've already mentioned these to some extent, but peripheral neuropathy and skin reactions are the ones where I am most concerned about patients. and where they did lead to dose reductions. So do these improve? Well, obviously, within the study, this is pooled data across the monotherapy and the doublet study. 58% of patients' rash improved, but 42% did have a residual skin reaction, and just under 40% had a residual grade 2 or more skin reaction. And this is what it looks like. With a peripheral neuropathy, which is more worrying, 50% of patients had residual grade 2 or more peripheral neuropathy, and this is from the this is from data in the States, looking at the Unite data. So these are our options, and as I said at the start, isn't it brilliant that we've got options? But how do we choose when we have options what is best for the treatment in front of us? Well, we just have to assess the patient carefully, assuming that we do have access to all of these options. So we need to consider all of these treatment options. We need to think about the disease itself, but also patients' comorbidities. Are they hypertensive? What's their renal function? Are they diabetic? Do they have a diabetic nephropathy? How well does it work? Can they get each of these treatments, and how much do they cost? At the moment, our regulators in England are reviewing the cost efficacy of EV Pembro and also erdafitinib. I remain somewhat pessimistic as to what the final decisions would be. The other thing is about treatment duration and where is the patient going to be treated? How much are they going to have to travel? How familiar are people in managing toxicities when they are newer toxicities, and embedding the patient at the heart of all of this? So with the newer treatment options, some people may not have had access to use of, for example, EV Pembro or erdafitinib in the second line setting. So it is, I think, important to think about defining potential eligibility or ineligibility criteria. After all, I also treat things like testis cancer. And although I've been doing this for many years, I use criteria for bleomycin such as age over 40, cumulative dose of bleomycin, GFR, and lung function, all to decide whether to give somebody bleomycin. But at the end of the day, with 20 years of experience, I can apply those published criteria to my own knowledge and experience. But if I'd never used it before, I would want to have a framework to at least guide me in terms of patient selection and also management of any side effects. And I don't think our emerging drugs, whether that's looking at checkpoint inhibitors, whether it's looking at EV Pembro, whether it's looking at erdafitinib, are any different. So obviously, many years ago, the great Matt Galsky came out with criteria for cisplatin ineligibility. And these quite rightly were updated by Shilpa Gupta doing an audit of a number of oncologists, predominantly in America, to say, what now would you think about criteria for platinum ineligibility? Because in my 20 years as an oncologist, to be honest, I've never used a creatinine clearance of less than 60 as a reason not to give cisplatin. If that patient has a GFR of 50 or above, I've always given it as long as they fulfilled the other criteria. So these were the updated criteria for platinum ineligibility, which I think are very reasonable. And as I've already said, these are important, certainly in Europe, because we have the framework of EV Pembro being only for patients who are platinum eligible. It's different in America. So together with my colleagues Enrique Grande, who was the leader of this, and Ashish Kamat from the MD Anderson in the States, we came together with some draft criteria for patients who may or may not be suitable for treatment with the new combination of EV Pembro. And that really is for people who've never used it. So this is a work in progress. And at the moment, we're doing a survey of people across the world to see how we can best refine this and whether people think it is important, particularly if they've never had access to using this combination. So obviously, it's people who meet the trial exclusion criteria, people with specific comorbidities, patients who have alcohol overuse just because of the mechanism of action of the drugs, patients with a poor performance status, and also We need to always know the social situation of the patients. You're very fortunate, I think, in India that you do look after your older relatives and you do this with great love and care. But people in other countries are not so loving of their extended family. And we do have a lot of people in Europe who live alone without appropriate healthcare support if they're going through treatment. And that's not just about logistics of getting to treatment, it's also being about reporting side effects and managing side effects if they're living alone. So if we look again at those safety outcomes, you can see again the ones that we might want to look out for and how common they are in EV302 compared to chemotherapy. And so these were our proposed initial EV criteria, ineligibility criteria, which were in a letter to the JCO, which seemed to stir quite a lot of comment. And this was patients, obviously patients of poor performance status, patients with uncontrolled diabetes, patients with a poor GFR. Now, that's not a poor GFR due to obstructive uropathy from their cancer. It's because perhaps they've got hypertensive nephropathy or diabetic nephropathy, significant corneal or retinal abnormality, and also grade 2 or above sensory or motor neuropathy, which I think on its own would give me pause for concern. But we felt that at least 2 of these together, once things start to stack up, you may be more concerned about giving this sort of treatment. And this, as I've said, is a work in progress. So aren't we lucky? We have all these studies that have shown a survival advantage for our patients. The Javelin Bladder 100 with a median overall survival of over 29.5 months. The EV Pembro 31.5 months. But as I've said, we do have that missing data, those patients that went in the last few months of EV302 who got chemotherapy and then switched maintenance to avelumab. And I would really like to see what those results are. And then the subsequent Checkmate sub-study with a median overall survival, you've already heard my thoughts on this, so I'm going to move over swiftly. 2 other thoughts, real-world evidence and sequencing. So what we do to start with patients will affect what we can do down the line. Real-world evidence is that the patients that we see in the clinic are different to those in the trials. So I think real-world data is incredibly important. And I'm so grateful for my colleagues like Philippe Bartolome, who've produced data like the Avanan study, looking at sequencing in real life, and all of my colleagues across the world who produced their real-world data in this setting. So what we do in the first-line setting will affect what we do in the future. At the moment, we know that if patients have gone on chemotherapy switch, then we do have, depending on reimbursement and access, the opportunity of giving EV monotherapy or erdafitinib for biomarker positive patients. In the EV Pembro group, there is this evidence gap at the moment as to what we should give next line. There's obviously things that we can give, but we don't necessarily have that data, which is again why real world evidence is going to be very important. And the Avanan study from France is really useful for this. So this is the Avanan study, and we can see that this is an ongoing study, but with 4 years of follow-up at the moment. With these are the results for overall survival for patients who had chemotherapy and switch maintenance. And you can see that the survival is very similar to what we saw in the Javelin Bladder 100, with overall survival rates of 26.3 months, median follow-up of 26.3 months, but about half of patients being alive at 2 years. So in the real-world setting in Javelin Bladder 100, about 3/4 of patients went on to maintenance chemotherapy. In Avenance, it was higher, it was 82%. And that's because you need to look for these patients, and that would reflect what I see in my practice. What about discontinuation of treatment or moving on to second-line treatment, where you can see that 17% of patients went on to best supportive care, but the majority of patients went on to a second-line treatment. So those rates are really high, aren't they? And after 2 years of follow-up or more, 3 in 4 patients in this study were either still getting avelumab or had gone on to second-line treatment. So we're still alive. This is a contemporary sequence of the Javelin Bladder, therefore, followed by second-line EV, which I find very intriguing. This data shows that for those patients who have had these drugs, remembering that this is chemotherapy with switch maintenance and then EV, alive with a median overall survival at 40.8 months. Isn't that fantastic? And it starts to, in my mind, mean that I should be thinking how this compares with using other regimes in this first line setting. In the Japanese real world data, median overall survival of 40 months. Sorry, that is my timer telling me I'm slightly overrunning. 40.3 months for patients from the start of first line platinum based chemotherapy. Again, very similar to the data that we already have with other treatment regimes. Another Japanese real world study has shown 42 months overall survival. In EV302, we have at the moment some data about those patients who go on for second line treatment. About 60% of patients in the chemotherapy arm did go on to subsequent checkpoint inhibitors, but 40% didn't. They weren't well enough to do that. That data collection is obviously ongoing. So when we're thinking about sequencing, obviously we have that data lack. We do need to know how we manage toxicities, how many patients might be cisplatin eligible in the second line setting. Could we think about avelumab maintenance? What about if they've got cumulative toxicities, if they come into second line treatment with the neuropathy? How do we manage that? I don't have the answers. So as our landscape evolves, it is so important to understand how therapies are being used in practice and what is their impact on the real world. Real world studies with the Javelin Bladder 100 trials, I think are very reassuring for me and for my patients. We can see that the progression-free survival, the overall survival, is very similar or better than in the registration study. And in multiple exploratory real world studies, up to a 40.8 month median overall survival has been seen using chemotherapy and then switch maintenance and potentially going on to EV in the second line. Those are survival data that I could never have imagined a few years ago. So the important thing in improving our outcomes is to remember that patients want quality of life. So when we're thinking about the optimum treatment, scheduling and duration, we need to input that. So this is the shared decision making that we need to think about the best choice for each individual patient and look at those individual factors for each person. There may be some patients who aren't going to be suitable for EV Pembro, and I do think that we need to think about eligibility criteria for them. And never forget about this person, because his or her choice is going to be the reason why we choose what we do. Thank you very much.
Thank you so much, Professor Allison, for the excellent lecture. We already have started to get some question and answer in the chat box, but we'll take them during the moderator session. Nirav, if you can start sharing the screen, please. Up next, we now move into the panel discussion, which will be moderated by Dr. Vinit Talwar, sir. Nirav, if you can share the screen. Thank you. Joining Dr. Vinit Talwar sir in the panel will be, of course, Professor Alison Burton, Dr. Anita Ramesh, Dr. Amit Rautan, Dr. Mola Khade, and Professor Akhil Kapoor. Professor Amit Joshi is currently actually stuck up with that TMH in Mumbai, so he may not be joining in, but we have the rest of the panel. And our moderator, as I spoke, is Dr. Vinit Talwar sir, who is the Director, Department of Medical Oncology at Rajiv Gandhi Cancer Institute and Research Center. Dr. Vinit Talwar, sir, I want you to take the proceedings ahead.
Yeah, can I please? So we would be discussing on the optimal management of
Dr. Talwar, sir, sorry, your voice is a bit cracking up in between.
Hello, next slide, please.
Yes.
So these are the panelists which
Vineet, we are losing your voice in between. We're not able to hear you. Vineet, can you hear me?
Dr. Vesa, we'll try to reach out to Dr. Talwar via phone. Just give us a moment. Professor Bertel, in the meantime, that Dr. Vineet Talwar is joining in, there is a question in the chat in the Q&A section.
Oh,
Uh,
I'll have a look.
Yes, especially addressed to you. If you can please look at it and share your opinion. I'll just read it out. Dear Professor Bertel, there is a 60-year-old female seen by a urologist, upper urinary tract urothelial carcinoma, underwent radical nephrouretectomy with bladder cuff excision. Intraoperative, the tumor was adherent to iliac vessels. She underwent radical radiotherapy and referred to the medical oncologist. PET CT at this time does not show any disease. Can the Javelin Bladder 100 be applied here? And how can we proceed further?
Well, that's quite a tricky question, because first of all, I think the role of radiotherapy as a adjuvant treatment in upper tract disease is, if this was adjuvant, if the patient had had a nephroureterectomy without any systemic treatment, and then the decision was made to, based on a negative scan, just on the operative findings, to give radiotherapy, that would be slightly out of keeping with guidelines, to be honest. So if they'd had a negative scan and it was only the intraoperative findings, then that patient should probably have been considered for adjuvant chemotherapy. We know that the checkpoint inhibitors in upper tract disease don't have a role in adjuvant treatment. The subgroup was negative in both Checkmate and also in Ambassador. So UTUC adjuvant checkpoint inhibitor is negative. So I wonder whether Dr. Kulkarni might just fill me a little bit. Was that adjuvant radiotherapy that was given? Because, you know, I think this patient, depending on the date of their nephroureterectomy, probably needs adjuvant chemotherapy, in which case that is adjuvant. It isn't fulfilling the Javelin 100 data. Is that all right? Thank you very much. Checkpoint 901 positive, but the other two are negative. Well, I don't believe that nivolumab is any different realistically to the others. I just think it's the adjuvant bit, isn't it? It's the same as avelumab. So it's not the combination, it's the adjuvant bit here. So I think that's why. And I think when we look at, if we look at an adjuvant checkpoint inhibitor studies after cystectomy, for example, I also don't necessarily think that atezolizumab is a dreadful drug and pembrolizumab is a brilliant drug and nivolumab is a brilliant drug. I think probably if you look at the subgroup analyses and you look at if we had the circulating tumor cell data for those patients, we would probably see a mismatch in patients with high levels of circulating tumor cells in the subgroups of those studies, which is why I think the data from the observation arm of InVigor 11 is so interesting, because the 12-month data from that, which of course is a study where the patients are followed up for CTCs, and if they become positive, they're then randomized between placebo or atezolizumab. But if they stayed negative to 12 months, the data that Tom Poles has presented so far is that it didn't matter if they were T4 or N1, if they had the standard high-risk features, if their CTC stayed negative, they had a really good prognosis. So I personally think in the adjuvant setting, which is different to this, the optimum patient has yet to be defined. And I think if we give everybody who's PD-L1 nivolumab or everybody pembrolizumab, we're over-treating a significant number of patients. And I think the data on CTCs is really evolving here, and I would love to be able to use them. But I think that fits in with why, in the metastatic setting, probably we got, one positive and one positive some study and two negative studies, because it's the adjuvant bit is the monotherapy bit that's probably doing the stuff in the checkmate sub-study. And secondly, I think there's probably an imbalance in those subgroups between circulating tumor cells. How would I select patients to be counselled for the Javelin or the EV Pembro regime? Well, at the moment, I don't get put into that position and I may never, with our funding bodies in the UK, be able to be in that fortunate position. But I think there are going to be some patients who clearly I would never give EV Pembro to. If they've got a pre-existing peripheral neuropathy, and if we start stacking up a bit of renal failure, performance status borderline 1, between 1 and 2, and they've got a couple of other comorbidities, I'm going to be more nervous. And I've managed toxicity of EV Pembro. And I would say that compared to, all of my colleagues in the UK, unless they've done the first or second line study, or unless they use EV in the private sector, where it is the most expensive of all the drugs, I think it's £70,000 sterling, then people don't have experience of managing the toxicity. I think and the key thing about managing toxicity is that early dose reduction and pausing. If you do, and having really good skin care, the same as with checkpoint inhibitors, you have to have really good skin care from the outset, monitor skin, get patients to ring you if there's a problem. If people get a rash with a checkpoint inhibitor or with a combination treatment, then we may need a biopsy, but we need to intervene early and check obviously mucosa and eyes and things. But if I had somebody who was very fit and was suitable for both of them, then I would sit down and be honest, and I would talk to them about the survival. I would find out what they wanted. Do they want to live as long as possible? Do they want to have as little toxicity as possible? Do they want to reduce? Are they happy to have as many visits as possible, or as needed? And this is what I talk to patients about, the goals, gains, and pains of treatment, because you can't have it every way. So if their goal is to live as long as possible, their gain for it is going to be a survival advantage, which I can talk to them about both studies. And the pain of that will be the potential toxicities. So then with the toxicities, we explore what do they look like, how easy it is to manage them, because I still find it, despite the fact that we've been using checkpoint inhibitors for so many years in the UK, and we have all these guidelines as to how best to manage them, I still get patients coming in with a colitis from a checkpoint inhibitor who are sent home for an outpatient colonoscopy and who aren't giving steroids. So I do have some concerns when new drugs come in, and it would be the same with erdafitinib if that's funded, about how to make certain that everybody that might see the patient is familiar and knows how to manage side effects. But it is about that open discussion. If I had access to all drugs, what would I do? And the patient had zero comorbidities, and I would find out what they wanted. And I often find pulling up a couple of the slides like I've had in today's presentation quite helpful, because they're usually on my laptop, on my desktop in clinic. So I find it quite useful, and to be able to talk to patients that way. And if you're honest with patients and you say, these are the results, what do you want? But I think quite often, unfortunately, even in 2025, we can have a tendency as clinicians to be paternalistic.
Hello, Harsh, can you hear me?
Dr. Talwar, we can hear you now.
Hello, Dr. Tower. Lovely to have you back.
Terribly sorry, this network issue here. Can we have the next slide quickly, please?
Dr. Tower, I wouldn't worry. I've been answering the questions to my best ability that we've had from the audience, and I have filled in.
Thank you so much. Thank you so much. Really appreciate it. So now quickly we'll go to the milestones. As you have already alluded in your excellent talk, we started with the GEMSIS, and there was a hiatus of about 25 to 30 years. and only now we have got the first line maintenance with Avlumab, and we have the overall survival difference. Next slide, please. Here, the first question is, how will you incorporate these milestones in your clinical practice? So first I'll ask Dr. Akhil, and then Dr. Amit Rothan, and then Dr. Anita. One after the other, please. Dr. Akhil.
Yeah. So, sir, as you were highlighting, and we heard from Professor Allison, definitely what has happened that there has been a change in the practice after a very long time, and it was only chemotherapy, chemotherapy, and chemotherapy. But now, after having maintenance data and first time having a positive maintenance data, switch maintenance data, our practice completely changed, and it has become a standard of care. And thankfully, this trial was a very pragmatic design. It included both cisplatin and carboplatin, while most of the trials, like for example, Nevo trial, they included only cisplatin based on the previous phase 2 data. And we know that 50 to 60% of our patients are not cisplatin eligible in the real world setting. So this trial was pragmatic, change our practice, and this milestone is very, very important for us. And now, considering the cost benefit and everything, it seems that this maintenance available will remain the standard of care for a long, long time.
Thank you, Dr. Amit.
Yeah, hi. So I think all these newer therapies which have become available in the last few years have definitely changed how we manage cancer patients in bladder cancer. And I think having immunotherapy in various settings in bladder cancer and having it in various ways has really helped our cancer patients. And so definitely, I think no doubt about it, immunotherapy has changed the way we look at bladder cancer. Having new ADCs also, that's also changing our way we look at bladder cancer, and we are learning how to do things better and better.
Thank you so much, Dr. Anita, please.
Dr. Anita, you're on mute. Sorry, if you can please unmute yourself.
Yep. Am I unmuted? Hello, can you hear me?
Yes, we can hear you now, ma'am.
Yeah. So now is the era for the immunotherapy, and we talk about ADCs. Everywhere is immunotherapy, and I think that's the way to go forward. Even in, I would not say bladder, I will put it as urothelial tumors.
So I think all of us are on the blank. Can we go on to the please? Yeah, so this
Vinny sir, unfortunately, we lost your voice again.
we have did the
Thing is not audible.
Yes, right now it is not. Nirav, if you can take us into the subsequent slide, please. Next slide. A couple of more slides after this, please, where there are some questions which are posted for the panel. Maybe we can start to take them ahead. Maybe if I can request Dr. Amit Rautan, sir, your views after the Javelin Bladder 100, while we have seen the data being presented by Professor Alison Bertil, we'll request your views on the data, and when would you like to initiate Avelumab after first-line chemotherapy? Dr. Rautan, sir.
Yeah, so Javelin Bladder 100 is clearly impressive. It's changed the way we think because chemo was the way we used to think always, and maintenance. Uh, so there were the two negative chemo plus IO trials. So that's why it was almost thought that first-line immuno may not be that great till Javelin 100 came in, and then the thought was maintenance is the way forward, at least in this segment of patients. So clearly, it has changed. It's a positive study, which is very encouraging. I look at my patients where we give chemo first line, and we give them 4 cycles is what I do of gemcitabine with a platin drug. We do use gem cis as much as possible, but we do use a lot of gem carbo also in some patients who are unfit for cisplatin. And once we have got response, it may be partial response, it may be stable disease, as long as patients are doing well, that's the time we put our patients on to avelumab maintenance. So that's been our experience.
Thank you so much, sir. Dr. Akhil Kapoor, sir, if I can request your views on the differences between cisplatin or carboplatin-based chemotherapy, and any differences on the initiation of avelumab maintenance for these patients.
Yeah. So cisplatin fitness versus patient not being fit for cisplatin, it is itself it's a prognostic value. We know that patients who are fit for cisplatin are going to do well in terms of overall survival because of the inherent biology of the disease and patient's fitness status. So when the patient is fit for cisplatin, we know that the overall outcomes are likely to be better because of the inherent patient's fitness. And we know the performance status might deteriorate rapidly while the patient is on treatment. The best part is that the trial, Javelin 100, we saw that data is good for both cisplatin or carboplatin, and irrespective of whether we are utilizing cisplatin or carboplatin, the quantum of benefit from avelumab maintenance remains similar. So that's the most important point. I agree that patients who are receiving cisplatin, they're likely to do overall better because as I highlighted, but the quantum of benefit from the additional avelumab maintenance after completion of chemotherapy, it might be 4 to 6 cycles. I would like to stop chemotherapy and then start avelumab maintenance. So avelumab maintenance doesn't depend on using either cisplatin or carbo, but in fit patients we start with cisplatin.
Thank you so
Thank
much.
you.
Vinny,
Thank you,
sir, you're back.
Dr. Akhil. Dr. Amit Joshi is not there. So can I request Dr. Amol Akhade, how long would you continue the maintenance?
So as per the criteria of the trial, we continue it up to the toxicity or progression. So that's what we follow in the real world also. If the patient is doing well and there is no toxicity and no progression, we continue it, the available maintenance.
So till intolerance or till progression,
Progression,
we
yes.
can continue. Next slide,
Yes.
please. Next questions, please. So, what are your views about the available data of Checkmate 901 and how will you position it in the management? This Dr. Allison had very nicely alluded. So, if Dr. Amol could take this question, please.
So as it was discussed previously, that the Checkmate 901 data that is being presented is a subset of a bigger trial in which they initially wanted to have both cisplatin eligible and non-eligible patients, and they have an arm of 2 IO trials, EP plus Nivo, but they found that it's not working, so they eventually gave the data of only this particular subset of cisplatin eligible patients. So yes, it's a positive trial, but I'm not too much a big fan of that particular data because the magnitude of benefit is not that great if we consider with the previously established therapy of Javelin bladder trial, that is avelumab maintenance. So yeah, and there is a various theories why, as it was discussed in the previous talk also, that why one particular IO has worked and other two have failed, and there's some issue with the censoring of the data in that particular trial. So I'm not a big fan of that particular strategy.
So I agree with you. A PFS difference of just a few months and the overall survival PFS of few weeks and overall survival of difference of just a few months. I don't think it'll make it very attractive. Dr. Amit Rothan, what is your opinion?
So I would kind of say it's given us one more option. I would kind of think, why not? It's a positive study. It's enabling you to add immunotherapy upfront. You always worry that there'll be some patients who would progress off and would never get immunotherapy, and it kind of gets you away from that. The issue I would definitely agree, the curve starts separating after 6 months in overall survival. So probably maintenance would also give us the same benefit, no doubt about that. Uh, I I I struggle between, that decision of sometimes can we start the immuno early? And you keep wanting to do that in practice in some patients because some patients will become long-term responders, will get on the tail of the curve, and that's where the temptation comes into. But the other thing about is it is a positive study and you did increase response rates. Now, if you said no, the response comes only later, but then the response rates would not have gone up. You got up by 14% or 15% response rates. I think you got 10% more CRs in these kind of patients. So clearly there is some benefit there. I would say it is tempting there. The magnitude of benefit is not that great, and that's what kind of pushes us back again. We keep thinking,
Yeah, I was saying that only. The
yeah.
maximum benefit was in the patients who had lymph node Mets in this study. And second, it was a post-hoc analysis. And third, the benefit, actual benefit was about 3 months. So, Dr. Akhil, do you agree with Amit that you should give immuno and chemotherapy combination upfront, or would you like to give it in tandem like the Javelin trial?
Sir, so as sir was highlighting that it has given only one more option, but what we see is the cost benefit ratio. Since it seems that if you see the survival curves closely, and as Professor Ellison was also highlighting, the actual benefit starts when the patient comes on maintenance. So after 4 to 6 months of starting treatment. So it seems that during the time when Nivo is being given, it is not helping much. It is it's only in terms of days the benefit in terms of PFS. So it doesn't make sense to utilize costly treatment when it is not adding anything. And if we see, as I already highlighted, only 30 to 40% patients in the real world setting are eligible for cisplatin in the first line itself. So that makes most of the patients non-eligible for this trial data itself. So both points are there at the back of my mind.
So, I agree with you. And I think the last word from Professor Ellison. Madam, what do you feel?
Well,
How do you position this vis-a-vis the Avalumab study?
Well, you've heard what I have to say. I think it's absolutely a waste of time, sorry. And I think you're adding cost to patients in terms of treatment duration time when they're having their treatment during their chemotherapy, and you're adding funding cost to them as well. So I'm not very supportive. But I am going to throw something controversial into the mix because, as you know, I'm a clinical oncologist, which means that I'm also trained in radiation oncology as well as systemic therapies. So in each of the sub-studies, both for EV302 and for Checkmate 901, where they had and for Javelin 100, where they have the low volume nodal disease doing best. Of course they do. And actually, after chemotherapy, I would irradiate these patients with radical chemoradiation. Is what I do. I give them a chance of cure, and that's what I routinely do as a clinical oncologist. So I just want to throw that slightly controversial thing for you into the mix, but that's what I would do, and that's what most radiation oncologists would look at doing as well.
And then you would do limited immunotherapy and stop at 1 year, or you'd go on after that?
So, well, no, what I would do is if I've started with chemotherapy and I've got somebody with a T4N2 tumor, that it has a complete response, because we've seen that, response rates around 80% for patients. So if they've got a complete response, to be honest, I would, and particularly if they just had nodal disease within the pelvis, if it's all melted away, I would not give those patients any form of immunotherapy at that point. There's a few patients, but I would then give them chemoradiation. I would treat the bladder, and I'd add mitomycin C, 5-FU into that, and that's how I would treat them.
So you wanted to treat them like oligometastatic disease, extrapolating from the prostate?
No, that's what we've always done, to be honest. In the UK, we've always treated, if these patients have had downstaging chemotherapy, sorry, my heater's a little warm, then I would then give them, give them the chance of cure and give them radical treatment. And if they relapsed in the future, 3-4 years down the line, then depending on when the relapse is, then they can have a second bite of the cherry, they can have chemotherapy again, and then they could have maintenance treatment.
But madam, if I would have asked, how many patients would actually be put on this kind of regimen, there would be a small subset of patients,
Yeah,
right?
it's a small subset, but if you also look, so there was a publication in JCO. The first author was one of my registrars, Martin Swinton. The other authors were myself and Ananya Chowdhury. We looked at 4 centres in the UK looking at patients with node-positive disease who were treated with downstaging chemotherapy, which is what it is. It's not neoadjuvant, and then chemoradiation, and the outcomes are there. So that's a useful publication to go and have a look at. First author, Swinton.
Sure, thank you. So as we were talking about the side effects of these combinations, and now we are focusing on the Javelin study and the EV study, because now we can put the triple, that is Gemcis and nivolumab, in the back burner, as all of us had agreed. So, Dr. Akhil, what would be your take? Would you give something like maintenance, switch maintenance followed by EV, or would you go for EV Pembro, or would you think about the side effects and according to the EVITA platform, think likewise?
So, sir, we are seeing two important points here. One is, again, cost is really, really important. EV plus Pembro, I don't think it is going to be affordable for even European or American countries. So
Yeah,
that's
I agree with you.
so that's a very big load on the healthcare system. And even if it is affordable out of the pocket, we need to say about the toxicities again. EV plus Pembro is continuous chemotherapy. EV is nothing but chemotherapy combined with antibody. So we can't say that it is not a chemotherapy. So these patients are going to develop peripheral neuropathy. What we have seen in our experience with EV in the second line, we have a good amount of experience in the second line. We see a significant proportion of the patient developing grade 2 peripheral neuropathy after 4 to 6 months. If patient is diabetic, as we know already, it will develop much earlier. So giving EV in the first go and then patients making neuropathy very early, which is going to persist for a very, very long time, that has a significant impact on the quality of life. So that is very, very important. Patient who is very extraordinary fit, young patient, doesn't have diabetes, patient willing to tolerate the toxicities. We have seen corneal toxicities as well, and we have, that is why in all our patients, we do corneal examinations at every 2 to 3 months. And these patients will be very carefully selected. And as Professor Ellison was highlighting, we need to give all the information to our patients and give them the option to choose. But as a perception of a medical oncologist, I think EV in the first line, that will significantly not only cost, but as well as significant toxicities as well. So that is why.
Definitely, I agree with you, because the residual 50% of patients, if they have grade 1 to 2 neuropathy, it is a very tall order. So, Dr. Amit, you have a difference of opinion, or you concur with what Dr. Akhil has said?
So I agree about the cost and toxicity, no doubt about it. But I don't think we can disregard the way the responses are and the way the PFS and overall survival is. I clearly think it's one of the most effective regimes we've ever had in bladder cancer. I don't think in metastatic urothelial cancer we hit those responses of 67%, CRs of 30%, PFS of a year. We used to talk of survival of a year earlier. PFS of a year, OS is touching more than nearly 3 years. These are endpoints where you clearly say you have a very effective regime. Now, toxicity, I think as medical oncologists, we learn very fast. There is no doubt we are very fast learners. If you didn't have this option and this is the option and this is a toxicity, we are going to learn how to use it very fast. We are going to learn to dose adjust. We are going to learn to get to a proper way by which our patients can take it, and monitoring can definitely help. Cost is the major issue for our patients, and that's where we are definitely it's going to find a very, very difficult space. For that reason, I would clearly think that's going to be a very good difficult time. But I would say again the same thing, it's good to have options. we always like to have options for our patients. These are metastatic urothelial cancers. We want options so that we can improve patient survival. And that's why I think we can't keep, we'd like EV for that reason, because if we don't use it first line, we want to use it second line.
Right. I got your point. So
Thing not audible.
Unfortunately, Dr. Talwar sir, we lost your voice back again due to
Dr.
the network.
Amol, your comments, please.
About the toxicity part. So
No. Would you go the Akhil way? Would you go the Amit way? Or you have your own perception that comorbidities definitely do matter when the treatment is to be undertaken?
of course, the comorbidities definitely matter when treatment is to be undertaken. And I fully agree with Dr. Akhil and Professor Allison have said that it is a very, EV plus Pembro is a very difficult regimen to give. And if you see the EV302 trial itself, the average number of cycles that the patients would able to take in that particular trial was close to 10 to 12 cycles. So in a clinical trial setting itself, if you're not able to take all the complete number of cycles as planned, then in a real world situation, it is going to be more difficult. And whatever experience that people have across the world, in United States also and bit in India, everybody is starting at a lesser dose than what is being used in the trial because everybody is worried about toxicity. And I think we have a further discussion about that EVTA criteria. And Professor Ellison was the first author of that particular letter and has received a lot of reactions from the urology community across, uro-oncology community across. And people don't want to talk about them. I'm very surprised why people are not talking about toxicity, when they should be talking about toxicity. And it is a really difficult regimen. And yes, Professor Dr. Amit said that we will learn, but we will probably end up learning at the cost of patients' lives. So it is not an easy regimen to give, and I will prefer to keep it as a second line option after progression on after javelin bladder approach, that is giving alveolar maintenance. Keep EV for the second line. That will be probably a preferred option for me.
Okay, so we have two for the switch followed by EV, one for EV upfront. Let's say what Dr. Anita says. Dr. Anita, what is your viewpoint?
See, this is a very potent regime with pembrolizumab EV, and we have seen success rate of pembrolizumab and ADCs in other malignancies as well. For me, I will stick to javelin first, using the platinum gemcitabine followed by avelumab maintenance. If patient fails, then I would do an NGS to see that there are no other mutation. My second line will be pembrolizumab EV. And yes, toxicity, all these are common discussion which happens everywhere. Okay, we have learned and we can definitely manage. Financial toxicity is what we depend upon the company for PAP program, but definitely we have something to give to the patients once they fail.
Very aptly said. So I think we have diverse views.
I
Three
just want,
people for the switch and
could I ask,
one for the EV.
it's
So
Alison.
let us ask Dr. Allison. Madam, you are the third umpire in the cricket match. Yeah.
So it's really
She is the author of the paper of the EVTA trials, so the EVTA criteria. So
well, it's really interesting. There are two things here. First of all, if you look at the Unite data, that was a poster at ESMO last year looking at EV Pembro in the real world, the response rate was significantly less than we see in the registration study. So that's one thing to bear in mind. In my head, I compare and contrast that with the real world data from chemotherapy switch maintenance, which says that no matter who's published that data, which country it's from, the real world data shows that the response rate is either the same or, certainly in Philippe Bartholomew's hands in France, better than in the registration study, and that there were no new toxicity concerns. So that tells me that people are either starting off on a reduced dose and that's affecting efficacy, or patient selection is wrong, or the patients that went into the study were so super brilliantly wonderful that they don't reflect my patients today. So that's why I think real world evidence is very important. And as I said during my talk, I treat patients with not just prostate and urothelial cancers, but I also treat patients with testicular cancer. And we've had criteria for as long as I've been an oncologist. We had the Galsky criteria, then the updated Gupta criteria for platinum. We've got in germ cells, I've got bleomycin criteria, age over 40, cumulative dose of bleomycin, GFR, smoking history, etc. Now, I don't use those exclusively because I've done the job for a long time, but I use them to start off with, and then I apply my experience and I bend them based on my experience. But if I'd never used them, I'd want something that told me who I should use them in rather than going in, killing a patient, which is the bottom line, isn't it? So we're not just talking about, a few small toxicities with any of these treatments. We're talking about major toxicities. And as I said before, peripheral neuropathy with EV monotherapy or in doublet, if a patient had any neuropathy at all, I would immediately stop and see what happened. And then look at re-challenging with a different dose, because as soon as you get grade 2 toxicity, it's symptomatic. Grade 1 means that either they've lost tuning fork sensitivity or their reflex has gone, depending whether it's motor or sensory. So grade 1, we can't do anything about unless we're spending time in the clinic with a tendon hammer and a tuning fork, and I don't currently do that. You might be far better than me and do that, but I don't currently do that. I only use my tendon hammer if I'm trying to see whether a patient's got a cord compression in my prostate population and then they need an MRI.
Definitely, madam. Thank you so much for giving the clarification. And now I feel the panel is all for giving the switch first, followed by EV, then going for EV Pembro. But those patients who have to go for EV Pembro, it is the EVITA criteria which you formulated. I think that should be the best bet. So patient eligibility and preferences, Dr. Amol, your thoughts.
So of course, if we're talking about our country, the financial toxicity is going to be a major thing. The one cycle of AV plus Pembro will go to close to 10 lakh per cycle, especially because there is no PAC program for both of these drugs. So I'm not so sure how many percentage of the patients will actually go for it, and I'm pretty sure that probably it won't be more than 1 or 2% of the total advanced urothelial carcinoma patients. So most of our patients will probably prefer to go for lesser toxic, both physical toxicity as well as financial toxicity, and that is why switch maintenance is probably the way forward. I think Dr. Vinith is again not audible.
Dr.
Amit Rothan.
Yeah.
So eligibility, definitely, I would kind of agree. It is this way. Cisplatin eligibility is definitely lesser. Only 50% of patients are eligible. So I don't think that will be. It will be a pan kind of a regime accepted. There is 70 to 80% patients are eligible to our switch maintenance, and that's a good thing in our patients. And I think that's the way it will be. So clearly we agree with this kind of eligibility criteria percentages in clinical practice.
Dr. Anita, in your practice, how does it work out?
Yeah, usually for these type of patient geriatrics, I do the geriatric scoring around 10 points to see how fit they are. Almost everybody will have a lot of comorbidities. And apart from that, this is cisplatin eligibility. Those points are also partly included in the geriatric scoring system. So yes, for my practice, 50 to 60% of the patient will be ineligible for cisplatin. Then we have to plan for carboplatin-based therapy with the adalimumab as the maintenance. And I stick to this regime mainly, and I will not be jumping into pembrolizumab EV at this point of time.
Can we have the next question, please? So, Dr. Akhil, real world evidence for the Avalumab study is very robust as against the EV Pembro study. What are your comments regarding this?
So, as we were highlighting, sir, avelumab maintenance has been there for a good amount of time. That is why we have real-world evidence, not only from Western countries and Japanese. We have our own real-world evidence data, and we have seen a good tolerance of the patients. Initially, there was the thought about infusion reaction issue, but it is not there now because when we are utilizing proper prophylaxis, it doesn't happen in most of 90% of the patients. And then the tolerance is much better, and it is predictable toxicities. While if we see the data from EV plus Pembro, it's a newer regimen. All are not conversant with the use of EV plus Pembro, and EV has a very different toxicity profile. So that means it will have a very long learning curve as well. And as I already highlighted, toxicity profile is completely different and will add quality of life becomes very, very important. Patient reported outcomes are very important, and till the time these trials give more details of the patient reported outcomes, it's difficult to adopt them directly.
I fully agree with you. Madam, this will be a reiteration, but you can again throw some thoughts on the real world versus the clinical trials.
I have to say that in my head, I have a picture of the clinical trials are, it's a bit like, I don't know if you've ever seen the Disney film Hercules. So the Hercules, when he's achieved his god status as the son of Zeus, is all muscly and powerful. And it doesn't mean that he's young. It just means that he is fit, very fit, maybe on very little in the way of other medication. And then the real world evidence is Hercules when he's just a human and he's a bit sort of, bit weedy, and certainly wouldn't be playing cricket for India. And these are our patients. They may be any age, they may be older, but their performance status is not quite zero. They've got polypharmacy, they've got other comorbidities, and those are what we deal with in real life practice. It isn't these super fit patients who, remember that in every single study, performance status 2 patients are very carefully selected. They are underrepresented and they are very carefully selected. So they would have no other comorbidities. They would be PS2, but their creatinine clearance would be fantastic. They wouldn't have anything else going on. So, and they're a minority subgroup in every single study we've ever done in bladder cancer. So I think real world data is the thing that also persuades our patients and persuades funders, because certainly NICE in England look at how applicable trial data are to the patients that we have in our natural population. So I think they're increasingly important to run alongside the phase 3 randomized data.
Thank you, madam. Dr. Amol, could you please highlight and describe a bit about the pseudo IPD generated KM curve, that is the larval curves?
Yeah, so this is see, the cross-trial comparison is the biggest sin in oncology, but all of the oncologists like to do those cross-trial comparisons. So we have this software or larval, they have a pseudo IPD curves from the published KM curves, and I just did this exercise of comparing the 3 urothelial advanced urothelial cancer trial OS curves, of course, whatever that is published till now. And what is an important thing is that, of course, the EV302 is superior curve. But if we compare between Checkmate 901 and JB100, the JB100 is definitely doing much better as compared to CM901. So that's the take-home message. Of course, the curves will, the data for the EV302 will evolve as the more mature follow-up comes up. But what it says grossly is that amongst the 3 options, the JB100 is definitely above the Checkmate 901, and EV302 is evolving, but that also has to be taken into consideration.
So, what would be, the final word as far as these curves are concerned? Although it is not fair to do a cross-trial comparison, how would you interpret it for our sake?
So, Justin, I will feel that when you're discussing with the patient, you have to give them all the options as a treating oncologist, and maybe a pictorial representation like this can help them understand that which one to go for. Of course, this doesn't reflect the toxicity part, but this is one of the way by which you can discuss the data with the patient, and that is where such kind of AI-generated aids help them. So what it clearly says that if there is a choice between JB100 and EV302, the checkmate 901 probably is not the first choice. So that's my take-home message of this
So, I
particular.
think that is a reconfirmation of what discussion we've been doing throughout. Such a small benefit as far as the PFS is concerned, and also not a great benefit as far as the OS is concerned. So, the checkmate can be put in the back burner. The only thing is between JB100 and the EV studies. So, coming to Dr. Amit, what is your opinion now, at the end of the discussion? How would you sequence it? Would you give still EV Pembro first, or would you think of the EVITA criteria and then progress, or would you give the switch maintenance first?
So we really don't have to take that decision because EV is not available yet in India. So that's not a situation to really bother about. I think clear
Suppose
cut.
it is available. It's going
Be
to be
ready.
available. I think couple of
You
months is
be
going to be
ready.
available.
You can't wait until that first patient comes into the clinic and you've been on holiday the week before when the approval was given, and somebody comes in with 15 family members and says that they want EV Pembro for their grandma who's sitting in a wheelchair. You need to know now what you're going to say.
So you make it quite
Yeah.
easy now. So anyway, I think the most commonly used regime and probably the most comfortably used regime in clinic is going to be the switch maintenance. The Javelin 100 is, whatever said and done, toxicities are very comfortable and very straightforward to use in practice. So we would always lean towards that as an option. And of course, getting new options for our patients is always beneficial in the long run in future.
Okay. Thank you so much, Dr. Anita. Your final words?
Yeah, I think the same thing what is discussed, that's what I follow. Javelin is my first choice, followed by second option. I would also do an NGS to see whether there are any other mutation before I start the pembrolizumab and EV.
Dr. Akhil, you have any difference in thought process, or the thought is the same?
Yeah, so sir, as we have highlighted multiple times, it is definitely the patient-reported outcomes which are very important. Patient's quality of life, discussion with the patient is important. But when the patients ask us to choose for themselves, this is what happens in our country very commonly. I think we all will agree that presently the most efficacious and cost-effective way is the Javelin way.
Uh, so I think there is a crystallization of thoughts from this panel discussion, and of course the expert inputs which have been given by Professor Allison. So what I gather is that between the three trials, the checkmate trial is a poor third, and between the EV Pembro and the switch trials, if the patient conforms to the EVITA criteria, then probably you can give the EV Pembro. If not, then definitely these patients should be given the switch trial, that is the Javelin trial. Of course, Dr. Amit has a point that there is a learning curve for every drug. Unfortunately, EV at present is not available in India. So there will be a learning curve, and probably we would learn more. But I think till that time, the thought process is that we give Javelin, and then after that we go to the EV. And I think the final words by Professor Allison. How would you, madam, now as of date, proceed as far as these three combinations are concerned?
I would wipe out the idea of Gemsys and Evo. You've already heard that I'm not very excited about this. I currently would give chemotherapy switch. I really want the discus data because patients are getting tired by the time they get on their 4th or 5th cycle of treatment. And sometimes you want you'd love any excuse to stop earlier, but we don't have that data. We should always follow the data. If you need to stop earlier, I don't believe currently you should be giving maintenance of avelumab because that's outside of the trial data. So it needs to be a minimum of 4 cycles of chemotherapy. What's going to happen if we ever get EV Pembro? Then I would have the discussion, as I said earlier. And I would also say to patients that there is some missing information that we don't have, about which we can only speculate, which is that group of patients in EV 302 in the last months of the study who got chemotherapy switch in the standard arm, and we don't have the data for them. And it may be that they, we know that the chemotherapy group does a bit better than normal in EV 302. It may be that they're biasing the results of the study, but then dragged down by the results of the rest of the chemotherapy. And I'd really like to see that. But I think it's asking what the patient, what they want, what do they want to go for, and then looking at those comorbidities. And I do believe we need the criteria for use. Otherwise, I wouldn't have worked with my colleagues Enrique Grande and Ashish Kamat to produce the EV criteria, and that is a global study that is going on at the moment, collecting the data. It's a global survey, which I hope very much that it has been shared with colleagues in India.
Okay, thank you very much, madam. Akhil, you wanted to make a point?
Yes, sir. Also, Nectin-4, as we were discussing initially, Nectin-4 is not so common, though it is commonly expressed in 90 to 95% of urothelial bladder cancer. But there has been now we have an option of doing Nectin-4 amplification. If Nectin-4 amplification is there, it seems the response rates to EV in the second line, it is to the tune of 70%. But if it is not amplified, the response rates are only 21%. So this might be one of the criteria, though not yet validated. But it seems that if we see for the biomarkers, Nectin-4 amplification will come a very long way. Though it has not been popularized till now, there has been an ESCO paper last year which showed that Nectin-4 amplification is an important biomarker for response to EV. So if we have to choose a drug which has its toxicity, I think we'll in some time we'll have some more data and we'll be able to do that. And we have incorporated Nectin-4 amplification by in-house test.
Oh, that's very good.
I think
Yeah,
that's
Dr.
a brilliant
Ellison.
point. I think that's a brilliant point because there is a lot of controversy about Nectin-4 testing. Tom has published the data from EV302 and said that his belief is that we shouldn't be testing for it because it doesn't matter the level of expression, that you get benefit irrespective of whether it's low or high. However, the German groups have published something different with a different assay, and we don't have the methodology. Sorry, my cat's standing in front of my camera. We don't have the methodology of the assay used in 302 to be able to replicate that outside of the study. Our German colleagues have got significant data and experience in the real world looking at expression, whether that is membranous or not, and they would suggest that actually expression of that differs and that it does make a difference. So I don't think the answer here is settled at the moment, and I think that the Nectin-4 story will carry on. So thank you so much for bringing that up because I've forgotten about that.
Thank you, madam. So I'll put a case, a very short case. So here's a lady, frail lady, who has borderline GFR, say about 30, 35. And we put her on pembrolizumab as first line. And then she progresses in, say, 2 cycles. Then we put her on split kind of gem-cis combination. And then she has a partial response. Now we are completing 6 cycles and she continues to respond. Now she has a very good partial response. Now the question is, should we reintroduce avelumab or should we straight away go to EV, or what should we do? Madam, this is for you.
So I have to say in the UK, it would depend on what the reimbursement is. We don't have data on sequencing of checkpoint inhibitors. I would also argue that checkpoint inhibitors as monotherapy takes such a long time to kick in that in this particular case, if she'd only had 2 cycles, we don't know whether it was working or not, because the checkpoint inhibitors on their own take longer to kick in, for the initial response. So I would argue this, if I wasn't allowed to do it because of reimbursement, if I wanted to use a checkpoint inhibitor again, I would argue that she'd not have a fair trial of assessment, that she was not proven resistant to a checkpoint inhibitor. So if she'd had chemotherapy and it had a good response, if she'd had, she'd be perfectly with that GFR able to have carbogemcitabine, I would probably look at dose reductions of that, get her to 4 cycles of treatment if she was tolerating it well, and then look at avelumab maintenance. I would have concerns with frailty and GFR to give her EV pembro in that setting. But I think the whole thing about had she had enough of a checkpoint inhibitor is she hasn't had enough, because she hadn't had enough to be able to see if she was responding or not at that point. The question would have been, should she have had chemotherapy to start off with, I think. And if she wasn't fit enough, I'd have given her dexamethasone to get her performance status up to see if she was fit enough to have chemotherapy. Sometimes you do that for a week, then see them back in clinic and they're a lot better. But again, it's about the support of the patient, isn't it? If you've got a big loving family to help support them, if it's different if they're living on their own and they're not even going to be able to get their shopping in, for example. So you do have a much better family support system for many families in India than in many other countries in the rest of the world, certainly in the Western world, where social isolation is very common, sadly.
Thank you very much, madam, for those enlightening words. And at the end, I would again profusely apologize for the network problems, because that is something which is beyond my control. But despite that, we had a very good discussion, and we have a thought crystallization as to how we have to sequence and which combination can be relegated to the third position and which one has to be the contender. So with these words, I thank all my esteemed panelists, and back to you, Harsh. And very big thank you for Professor Allison.
It's been an absolute joy and delight. Thank you so much for asking me.
Thank you.
Thank you.
And may I please
Thank you.
quickly invite Dr. Ved sir for the closing remarks?
Thank you, Harsh. And I know we are way behind schedule, and great discussions, a lot of learning in the last 1.5 hours, and so much of intense academic discussions. And ultimately, I think it's the case selection, patient selection, because there would be comorbidities in these patients. A lot of them come from history of smoking and many other organ dysfunctions. And the sequencing ultimately will also be of a great concern. And we have seen that there could be a chemo, avelumab, and a second line, you go to 40 months. And you could choose a EV Pembro, but I tell you, everybody is going to go bankrupt if you put everyone on Pembro EV. And the skin toxicity is something really to be to contend with, and especially in a tropical country like India, And we all learn to manage the toxicities, but obviously the learning curve is over for the IOs, and then we are so very comfortable, and we are past that. We are on the other side of the mountain, and the other mountain is yet to climb. And obviously, one size will not fit everyone, but then a lot of it has been already known in the clinic. And thanks once again, Harsh, Professor Ellison, and Vineet, and all the panelists. And thank you for inviting me to this meeting. Back to you, Harsh.
Thank you so much, sir. With that, we definitely come towards the close of this session. Apologies once again that we ran over time, but we saw the clinical questions coming across, and it was thanks to the faculty for taking their time out today, sharing their clinical experience, and also the data experiences also. Professor Alison Bertel, thank you so much for accepting our invite. As you were saying towards the start of the meeting, we definitely hope that India England match series are set up and we can invite you for some physical visits to India, and this case experiences and experience sharings can continue. Dr. Vaid sir, again, thank you so much for the great leadership to lead this as a chairman. Dr. Talwar sir, our other panelists, Dr. Anita Ramesh, Dr. Amit Rawathan, Dr. Amol Akhade, and Dr. Akhil Kapoor for their experience sharing and bringing in important clinical points. To our audience today, we had close to 180 HCPs who had joined us. Thank you so much for joining the webinar. We'll also request feedback. So there is a feedback option on the webinar. If you all can provide in your feedbacks, that will help us for future events to modify the scientific communication appropriately. With that, once again, thank you, faculty. Thank you to the
Thank you.
audience. Have a good night
Thank
ahead.
you. Thank you.
Thank you.
Thank you so much.
Have a good day.
Bye.
Bye bye.
Thank you, Professor. Bye.
Bye.